and welcome to Breakpoints, the Society of Infectious Diseases Pharmacists podcast. My name is Rachel Britt, and I am an infectious diseases pharmacist at UTMB Health in Galveston, Texas. If your conference attendance has been anything like mine in the virtual era, you might feel like you've missed out on all of the buzz around the breaking scientific research that comes out of ID meetings. Fortunately for you, though, and for me, I have two perfect panelists to fill us in on two important late breaker trials from ECCMID 2021, Overcome and MARINO-2. Our first panelist today is Jason Pogue. Jason is a clinical professor in the Department of Clinical Pharmacy at the University of Michigan College of Pharmacy and an infectious diseases clinical pharmacist at Michigan Medicine. Go Blue. He also is the clinical pharmacy lead for the Overcome trial. Welcome, Jason.
Hi, Rachel. Thanks for having me. Always a pleasure to come on Breakpoints.
We're glad to have you back. Our next panelist, Adam Stewart, is an infectious diseases and microbiology registrar at Royal Brisbane and Women's Hospital and a medical research fellow at University of Queensland Centre for Clinical Research. He also is the first author of the recently published MARINO-2 trial and lead investigator of the ongoing MARINO-3 study. Thanks for joining us, Adam.
Thanks very much, Rachel. Glad to be here.
Okay, I'm really excited to get started, so we'll jump right into it. First, the Overcome study looked at the efficacy of colistin monotherapy versus colistin meropenem combo therapy for bloodstream infections and pneumonia caused by extensively drug-resistant gram-negatives, including Enterobacteriales, Acinetobacter, and Pseudomonas. It's also the first and only randomized double-blind placebo-controlled trial for the treatment of XDR gram-negatives. While the first MARINO trial gave us insight on how to best treat extended spectrum beta-lactamase producing bacteria, the MARINO-2 pilot randomized controlled trial looked at piperacillin-tazobactam versus meropenem for the treatment of bacteremia due to AMP-C producers like Enterobacter, Citrobacter fundii, Morganella morganii, Providentia, and Serratia marcescens. Before we can get into the details of these studies, though, we need to talk about the challenges in conducting pathogen-directed clinical trials in the gram-negative resistant space. Jason and Adam, what difficulties did you encounter while conducting these studies?
Yeah, I'm glad you brought this up, Rachel. Challenging is an understatement, in my opinion. I certainly was probably unprepared or underprepared for what we'd really have to deal with. And just to kind of put this in perspective for everybody with regards to Overcome, I was 2 years out of residency when we wrote the protocol for Overcome. We enrolled our first patient in 2012, and we just wrapped up our study with 425 eligible patients this year in 2021. So we're literally talking about it took us a decade to complete this trial because it's a difficult patient population, challenging drug selections, things of that nature. And so I like to talk about, why, and I think it's really important for the audience to appreciate some of the issues that come up and make it really hard. And hopefully, as it makes it so whenever you read these publications, maybe you give us a little bit of a break and not tear us apart too much when you look at our methodology and everything that comes up, because there are a lot of challenges that you have to kind of deal with. Just talking about my experience with Overcome and our experience, why did it take us a decade to complete this? This was a study that was funded by the NIH. And so because of that, we're very thankful for that, by the way. Obviously, our intention was to complete this study in the United States. And so when we started this study in 2012, we had about a half dozen sites. And I actually thought that was a pretty good number in Detroit, New York City, Miami, and Columbus, Ohio. And we're going to let the Columbus, Ohio thing slide here today as a Michigan Wolverine. We're just going to let that part slide here today. But while we had great investigators and I had a really enjoyable time working with some brilliant people at those sites, the problem was, or the issue was, is that the number of patients with an XDR gram-negative bloodstream infection or pneumonia are just extremely low in this country. So you have 6 sites. It's just not a common disease state that you see here in the United States. Then if you think about as this developed over the 2010s, what happened? Well, we had the arrival of a bunch of novel agents for the treatment of CRE and XDR Pseudomonas. This is great for patients. These are better therapies than the ones we were investigating in this trial. No doubt about that, but it killed us, right? Because then you had another kind of hurdle to get past because we wanted people to get the best drug first. And so what we learned very quickly, and this is such an important lesson for anyone who wants to try to do studies in this space, is that good investigators is important, but you need both good investigators and sites with sufficient numbers of potentially eligible patients. And it's really challenging to put that together. And I would argue that in the United States, particularly if you're talking about XDR gram negatives, it's impossible. Luckily for us, we had a very committed group at the NIH led by Dennis Dixon, who really wanted to see us succeed, and they allowed us to branch out overseas. And thanks to some great investigators in Thailand, Taiwan, Israel, and across Europe, we were actually able to complete this study, again, 9 years later. Rachel, just to kind of put this in perspective for you and the audience, to enroll 425 patients into Overcome that were ultimately eligible, we screened over 12,000 patients over a decade. So again, it's a really challenging thing. It's why you don't see a lot of stuff come out in this space. The other thing I want to talk about real briefly, Rachel, is just that, again, we were talking, and when we designed this study, we were really focused on carbapenem-resistant Acinetobacter. And you know, right, when you're talking about Acinetobacter, you're usually talking about pneumonia, you're talking about complex patient populations. And Rachel, just think of someone who you're taking care of at your institution right now with CRAB, right? It doesn't happen frequently, but when it occurs, you're talking about Acinetobacter growing from a respiratory sample. The patient is often a clinical mess with every comorbidity known to man. The diagnosis of pneumonia is often soft, or you can't be sure because they have a lot of other cardiovascular and respiratory issues going on. And so what we learned, and again, one of the challenges and something to think about when you're interpreting these data, is that you really have to be pragmatic about inclusion criteria. You know, it's nice to have a textbook definition, right, for pneumonia, new chest x-ray showing infiltrate, this, and that. But if you limit your inclusion to that, you're never going to enroll anybody. If you're going to only want absolutely positively 100%, they definitely have carbapenem-resistant Acinetobacter baumannii pneumonia, you're going to really struggle to get patients. And therefore, over time, we had to evolve a little bit. Or again, the 9-year study would have took 35 years to actually complete if we did it that way. And so one thing that we did in our trial, and it's something that you'll see when you look at our data, is that we, again, trying to be pragmatic, trying to be realistic about what we're dealing with it. We weren't talking about comparing a new beta-lactam to an old beta-lactam, right? We're talking about using colistin. Nobody wants to give that drug to their patients unless they absolutely have to do so. And so because of that, we basically just said, if the provider, if the site PI and the primary team think this guy has pneumonia and they're going to treat him, we're including this patient because no one gives them this drug unless they absolutely have to. And so I know I rambled a bit there and I apologize for that, but just for me, what we learned over and over again through this trial is that there's a stark difference between ideal clinical trial and what's realistic or pragmatic to actually get the study done.
Feel free to ramble away. It's always helpful. And I can't tell you with CRAB, I can't tell you how many times that every time I see CRAB, which is not very frequently, fortunately, at my hospital, I'm texting Erin McCreary, who is very well known to breakpoints. What would you do for this CRAB? So yeah, really difficult question. And I applaud you guys for really trying to tackle this issue for us. Adam, what kind of difficulties did you guys have in Merino 2?
Yeah, look, just to echo some of Jason's points, I mean, you know, pathogen-directed trials against some of the sort of resistant gram negatives are amongst sort of the most important trials that sort of clinicians need to guide therapy, but incredibly difficult. And I'm sure this is a sentiment that's consistent with a lot of trial and investigators around the world. You know, even sometimes regardless of prevalence of MDR and XDR pathogens and infections, because the methodology is, and the conductance of the trial is quite difficult and has a lot of limitations. So a lot of the inclusion criteria, as sort of Jason points out, you end up having to take a very pragmatic approach due to a number of sort of early limitations. A lot of those are laboratory based. You know, for our Merino trial studies looking at bloodstream infection, you know, having that sort of delay in sort of microbiological diagnosis and, you know, susceptibility testing results before you can actually successfully enroll a patient can be quite sort of problematic, and it's very, very slow. So the window for enrollment in our trials and certainly a lot of other trials is 72 hours from blood culture draw. And that's really sort of like a Goldilocks balance between, having, that early treatment effect of being on trial drug, as early as possible versus, that delay and having that exposure early on to empiric or other therapy, which you're not really that interested in looking at. And obviously that's going to sort of dilute down your observed treatment effect. So that's really a problem. So as you know, in the lab, there's a number of ways in which to sort of diagnose or identify pathogens and perform susceptibility testing, and they have problems within within themselves. And as we demonstrated quite nicely in the Merino-1 trial, that there is problem with, in particular, piperacillin and tazobactam MIC testing, comparing, Vitek versus the sort of gold standard of broth microdilution. There is some inconsistencies there, and that would sort of change, change the sensitivity and resistant reporting and change clinician decision making on antimicrobials and even enrollment into the trial. So that we learned quite a lot from that. And obviously, a lot of these patients are on, as I mentioned before, prolonged empiric therapy, which is a big problem. And often, especially in Merino-2, they can defervesce or have rapid clinical cure, which means once again that's going to dilute your observed treatment effect, and you won't necessarily be able to sort of weed out those patients that would potentially benefit either from piperacillin and tazobactam or whatever your sort of comparator and control arms of the trial. So really a lot of difficulties there. There are some sort of laboratory assays and testing strategies that are coming out that are trying to improve this. Things like Accelerate Pheno, where rapid sort of diagnostics, BioFire are trying to help with that. And we're trying to sort of include some of those platforms in our future trials to try and improve the methodology of some of these sort of XDR, MDR, gram-negative trials.
Well, thank you guys for walking us through that. As ID clinicians, we're so trained to really critically evaluate all literature, and I think that's very important and a great skill. But we sometimes lose sight of really what goes into making these trials happen in the first place, and honestly, just being thankful. So on behalf of the ID community, thank you guys for all of your hard work, because findings from studies like yours are instrumental in shaping treatment decisions all over the world. So now we'll talk about Overcome. And first, Jason, can you explain how y'all designed your study?
Yeah, my pleasure. And so again, I want everybody to kind of go in their way back when machine, because when we designed this study was 2009. And so even though this study includes XDR-SUD, XDR Acinetobacter, and CRE, this was primarily designed as an Acinetobacter trial, because in 2009, that was our primary principal concern that we were dealing with, particularly in Metro Detroit, which is where we wrote the protocol. CRE was just coming onto the scene, and in the US, it was really only localized to New York City at that point in time. So I want to kind of highlight that when we were designing the study, it was focused on Acinetobacter. And what you're going to find is that that's actually largely what we saw, again, because none of the new drugs that came out really target Acinetobacter. So it was the one that we were really able to still enroll into the trial. So again, go back to 2009. And the big question, this is before Poly B was even a thing, that wasn't even a consideration for people. Colistin, the question is that Colistin has all these issues. We're just starting to learn about them. We still have concerns about being able to hit pharmacokinetic, pharmacodynamic parameters with the drug, even though we didn't really appreciate it to the full degree at that point in time. There was concern with giving monotherapy and resistance development. And so the big question is, when you give Colistin, is there a benefit to adding a second synergistic drug? You always see all this in vitro data, right, where you see this great in vitro synergy. But the question was, did that mean anything? Did that matter clinically? And so we designed it kind of in that backdrop. And I'll be honest, me personally, when I was learning about colistin in this time frame, I was actually pretty convinced that the issues surrounding colistin were largely because we weren't dosing it right. I thought that there was just really poor dose selection. If you can remember back in the day, there were all these different products. The conversion between colistimethate sodium and colistin base activity made people's heads explode. You know, the package insert dosing didn't even make sense. You couldn't really interpret it for when you were renally dosing. We just learned that a loading dose might be beneficial. And so what we really focused on in the study was, we're going to dose optimize colistin. That meant giving, at least what we thought was dose optimized in 2009, giving weight-based dosing, using adjusted body weight, having a loading dose, a good renal dosing schedule, like all the pharmacy geek stuff that we think about. That was a huge focus. And so if you did that, if you fixed it, again, in our minds, that was fixing colistin. We were wrong, but that's what we were thinking at the time, was that was fixing colistin. Is there a benefit to giving a second drug in combination, one of these synergistic drugs? And so the other group was colistin, same dosing, plus meropenem. And so the thing I want you to remember when you're reading the study, you don't have to send me nasty emails about it or tweet at me about it, but what I want you to remember about this study is that in 2009, we were going for synergy between colistin and meropenem. So the dose of meropenem that we gave in this trial was standard. It was 1 Q8 as a 30-minute infusion because we were going for synergistic dosing. And I still think that's okay. But just before you at me about this, remember that the 2 Q8 3-hour infusion stuff was CRE, didn't come out to the mid-2010s. Again, in Acinetobacter, you don't have those low-level resistant isolates, and so everything is high-level resistance. So again, this was meant to be a synergy look. So just keep that in mind when you're looking at it. In fact, one of our secondary outcomes, and we're actually presenting some data at ID Week on this, is for each index isolate in this study, Mike Ryback actually did time kill experiments for us to see if there's actually in vitro synergy and whether or not that impacted outcomes in patients who got combination therapy. So again, pay attention to that if you're attending ID Week. We're going to present some data on that. But that was our focus. That's how we designed it. We chose bloodstream infection and pneumonia because we thought it was what mattered the most, right? As clinicians in 2009, we didn't know what we were doing with regards to these therapies, and this was the problems that we were dealing with. We knew it would make for a messy patient population, but we also knew that it meant that it would be able to answer the questions we were interested in. We weren't interested in whether or not, combination therapy was necessary for urinary tract infections. And actually, we were kind of concerned that if we included things like UTIs, then you might actually dilute the effect that might come out with combination therapy, right? If it matters, we want to show it in the matters that in the patients that it's going to matter in. And then the other big thing we had to come up with was what outcomes were we going to look at. And so when we did this, again, and it's why I let in with the give us a little bit of a leeway when you read our paper, right, is that I read all the other publications that were out at that point in time. And, I was critical of some of the outcomes that people looked at. And what we really wanted to do was to overcome, again, that's not where we titled the study from, but we did want to overcome some of those limitations that we always have interpreting studies in this space. And honestly, one of the big ones is 28-day mortality. While that is our primary outcome in this study, and it has to be, it should be, because ultimately it's what we care about most, I always wonder when you're talking about Acinetobacter baumannii, right? Because we talked about this, those patients that you're dealing with, and they can cure their infection and still die within 28 days, right? And so our concern is that, we're going to dilute out any effect. And so one thing we really focused a lot on, and I will encourage you to take a look at this when you see our data, is our clinical failure definition, because we really, it's a composite of a few different things, but it's really looking at what we thought appropriate or better, if it is better, drug therapy would be able to impact. And so that was a big thing for that. In addition, because we're giving a lot of colistin, right, we were looking at safety. And then, as I talked about before, other questions were, does in vitro synergy matter on outcomes? So we look at that. And then also, one of the reasons that people think combination therapy for colistin is it might be able to prevent the development of resistance. And so that's another thing that we looked at, was the impact of combo therapy on that.
So what would you say are the most important findings from the study at this point?
At this point, yes. So at this point is key. We're still doing some final analyses, although I feel pretty confident that our primary analysis won't change in any significant way. So again, the one thing I want to highlight for those who will be thinking of this or looking at this publication is that it started off as a crab pneumonia study and it kind of ended there. About 80% of our patients in the study actually had Acinetobacter baumannii, and about 70% had pneumonia. And I think the headline is that no matter what group you looked at, whether it be overall, whether it be any organism subgroup, whether it be any infection type subgroup, there was no significant difference between combination therapy and monotherapy for either 20-day mortality or for clinical failure. So even our fancy, that propped up definition I just gave of clinical failure, we didn't see any significant difference between those two. That said, I am extremely deep. Adam can appreciate this. I'm very deep in this data set right now. And if you're asking me, which I guess you are because I'm on this pod, right? The data seem to suggest to me that there may, this is really good science language that I'm using here, but there may very well be a small beneficial effect to combination therapy. And the reason that I say that is that when you look at our outcomes overall, when you look at them in various subgroups, you see this signal pretty consistently for about a 10 to 15% advantage in the favor of combination therapy. And again, just to be like annoying, the p-values are like 0.1 or 0.2, just enough to tantalize you, but not be statistically significant. And then the stat police will come after me, right, to talk about all that type of stuff. But what really kind of is compelling-ish to me is the consistency throughout different bugs, throughout different infection type, and then for both of our outcomes, mortality and clinical failure. So I think that there might be something there, but as you suggested, the analysis is still ongoing. I would say that even if it is real, it's modest. It's very modest. Again, 10 to 15% relative reduction. And I do want to highlight that none of these end up statistically significant. The other thing I just have to say with regards to our outcomes, because some of our audience might not be familiar with colistin or using it a lot in patients. And I think it's really important to note that in both of our arms, they got big doses of colistin for 7 to 14 days. That came with an AKI rate, an acute kidney injury rate of 50% in both groups. And 1/3 of those cases were hardcore AKI, meaning the failure criteria in RIFLE, which is a 3 times increase in serum creatinine from baseline. So again, there's a reason that we say don't use this drug unless you have to. And these findings will really kind of support that.
So you're saying you're finishing up the primary analysis. What are y'all's other plans with the data that you have? And when is the full paper coming out? After all this talk, I'm really eager to see it.
Yeah, so again, like I said, there's actually an email sitting for me right now to open. I'm not going to do it on the pod though, but there's an email with those final analyses to look at. My anticipation, Rachel, would be that we'll submit this end of the month, early October, the primary manuscript. But then remember, as I stated before, there's a few additional analyses that we're going to present at ID Week on the impact of synergy on outcomes and combination therapy on resistance. And then we'll write those up. And then the other thing, just for the audience to be aware of, is that one thing we did as part of this study is we actually got pretty robust colistin PK sampling in a fair number of patients in both arms. And so down the road, once we get there, again, COVID permitting, allowing us to work on things that we actually want to work on, we'll be doing some pretty extensive PKPD and PKTD or toxicodynamic analyses, really to look at the impact of exposures on both clinical response as well as the development of toxicity.
So you're basically telling me that you're about to give the ID world the best Christmas present ever.
I like that. Sounds good to me.
Well, good. I can't wait to unwrap that in December. Let's pivot back to Merino 2 now. Thanks so much, Jason, for all that explanation. Adam, why did y'all decide to do Merino 2 as a pilot study rather than a larger RCT?
So I think this sort of segues quite well from earlier discussions regarding feasibility in some of these trials. It's always a multitude of factors, but originally the sort of Merino clinical trials group led by David Patterson wanted to sort of answer the question about carbapenem sparing therapies. And we were, watching quite worryingly around the world as, carbapenem resistant organism sort of prevalence was on the rise. And we were left often with limited treatment options. And what was really driving this drive of carbapenem resistance? So we looked at the most common indications, and that was certainly ESBL producing organism infections with causing severe infection and sepsis. And really ESBL and AMP-C producers sort of ticked the box for that one. Obviously, the first of Sentinel trial was the focus early on, and sort of trying to get a decent enough sample size to definitively answer that question, which was done really well by both David and Patrick Harris, that was published in 2018, Merino 1. And then, feasibility and funding limitations, all those things I'm sure Jason knows quite well. You have to make some decisions about how things are going to look. And I think the group thought that, having a small trial that's able to sort of demonstrate feasibility of this sort of pathogen-directed trial for AMP-C producers that hadn't been done before in an RCT setting, whether that could be done. And the information or clinical data generated from that would be quite useful. And we could be sort of left with a decision at the end to say, well, which way is it going to go? Are we going to try and make this into a larger trial? Are we going to incorporate different arms? And it gives you a lot more options. Unfortunately, and as I mentioned in the paper for Merino 2, recruitment was incredibly difficult. So recruitment started in early 2015 and ended in late December of 2019. So a 5-year period where we were only able to sort of enroll 79 patients, of which only 72 were eligible in the modified intention to treat group. And, hundreds and hundreds were screened. There were multiple sites, and it was really, really difficult. And as I mentioned before, there was a whole bunch of factors related to that. And so, and as a problem similar to Jason, the pharma and the whole world moves on. There are new agents coming out. There are, the Oviva trial, people are much more comfortable switching to oral therapy for severe and invasive infection now. So, as a group, you face decisions to say, well, where are our resources best put? And how should we move on to try and sort of solve some of these big problems in infectious diseases in the best and most economical way? And then, the decision was made to sort of, originally we wanted to enroll 100 patients, but the decision was made to sort of cut that earlier and, provide that sort of useful preliminary data and then move on. And in many ways, that's sort of in the form of Merino 3, which I'm also leading, which will be looking at ceftolozane tazobactam, both for ESBL producers and AMP-C producers with a much larger sample size. And so hopefully to answer some of those, questions a bit more definitively.
Yes, and Merino 2 actually is fully published and available. So I'm sure most of our listeners know that, but if not, you can go check it out in Open Forum Infectious Diseases. But Adam, can you walk us through what some of the key findings of the study were?
Absolutely. So look, the findings weren't sort of magical and somewhat, big practice changing, but they were very interesting and will sort of hopefully help sort of dictate or help inform future trial design. But essentially our primary outcome was a composite primary outcome made up of 4 components, one being the most important, which is mortality at 30 days, and then definitions for both microbiological failure and clinical failure, and then microbiological relapse. And that was that final one is where you would grow the index organism from the blood culture or sterile site within a 30-day follow-up period from randomization. So the baseline characteristics between the piperacillin and tazobactam group were fairly similar, and there were slight sort of numerical differences, not particularly significant, statistically significant. For instance, in the piperacillin tazobactam arm, there were sort of more healthcare associated and hospital acquired infection of their bloodstream infection. A lot of them had lines in situ, and the cause of infection was a line infection, and a lot of those had a delayed line removal as compared to the meropenem arm. And as I'm sure a lot of your listeners would appreciate, that when you get numbers sort of, in this sort of range, occurrences due to chance often happen, and which means sort of it makes interpretation a little bit difficult in terms of the primary endpoint when comparing two arms. So if you do have, a difference even of a couple of days of line removal between arms with a high prevalence of line-associated infection, you will, get a difference in certain endpoints that will be observed that may sort of be confounding the treatment effect, which is what, the difference between the piperacillin tazobactam versus meropenem. It may confound that observation, which is really what you're interested in terms of answering the clinical question. So in terms of looking at the composite primary outcome, there was no difference observed. So that's where they had to meet one of the four, or they could meet all four. There was no statistical significance between both arms. But what we noted on our sort of subgroup analysis when looking at all the individual components of the composite outcome, there were some interesting findings. So one being the sort of microbiological failure rate, which was higher in the piperacillin tazobactam arm compared to the meropenem arm, which was statistically significant. Now, as I mentioned before, there are a whole bunch of reasons why that could be possible. The most obvious one that stood out to us was the delayed line removal, and the fact that patients were, the infections were mostly acquired in hospital and sort of easily reversible or fixed, or more easily reversible or fixed. But it also brings up whether there is a mechanism related to this microbiological failure. And we looked into that a little bit more and did some further analyses, and found that of those who had an Enterobacter species infection, those in the piperacillin and tazobactam arm experienced more microbiological failures. And this finding was not statistically significant, but it certainly does raise that sort of biological possibility of selecting for de-repressed AMP-Cs or upregulation of AMP-C enzymes, leading to possible, clinical failure. And this is something that's certainly very interesting, and that, we should explore a bit further on down the track, because from a lot of those sort of primary studies looking at the AMP-C producers and AMP-C de-repression, certainly Enterobacter and Citrobacter are known to sort of hydrolyze or upregulate their AMP-C enzymes in the setting of beta-lactams, and hydrolyze these antibiotics much more readily and at a higher rate compared to other AMP-C producers like, Morganella species and so on. So that was really, really interesting. There was also some discordant results that surprised us. So there were more microbiological relapses in the meropenem arm. So that's where, they completed their trial drug and then experienced a microbiological relapse. And looking at the sort of characteristics of the meropenem arm, a lot of them were older, a lot of them had community-acquired infections, so potentially more invasive and harder to eradicate. And they received numerically a slight shorter duration of antibiotic therapy. So these are all sort of hypotheses as to, why these results were were observed, but certainly quite interesting and things that could be explored a bit more in the future.
As you were talking, it was like you were reading my mind. More of my questions kept popping up in my head for you, and you kept answering them immediately. So
Oh, good.
that was so great. And speaking of questions, you've mentioned that y'all are already working on Merino 3. So I want to know what questions you think still need answering after Merino 2, and if we're going to get any of those answers from Merino 3.
Yeah, absolutely. Look, I think, and this is with my statistical hat on, I think the biggest thing is sample size. You need numbers, and I certainly, the statistician working in our group, Mark Chatfield, he likes to talk in four figures, but often that is not feasible for a number of reasons. But I think with Merino 3, there should be a whole bunch of patients with AMP-C producing organism infections recruited, and we should get the numbers to be able to sort of definitively tease out whether some of these observations with beta-lactam, beta-lactamase inhibitors are real or clinically significant enough to change practice. We'll also do sort of further microbiological analyses in Merino 3 that could potentially, look at the activity in vitro of, ceftolozane tazobactam and piperacillin tazobactam. Certainly, a lot of these studies have already been done, and the MIC distribution or MIC values seem to be better or slightly lower on average, which is good. And looking at looking at clinical isolates, and you can do all sorts of things like RNA sequence analysis, where you can actually quantify the amount of AMP-C repression in some of these follow-up bloodstream isolates, to sort of put the big clinical picture together, to sort of say, well, the organism's been exposed to ceftolozane tazobactam or another beta-lactamase inhibitor. It's then been regrown after the patient's had a fever or a systemic inflammatory response syndrome, and then you can document or look at the biological explanation for that, and then compare it to clinical outcomes. And that's really what our group does, sort of to try and complete the whole picture, and then you can sort of input different antibiotics to sort of see the differential effects of that on bloodstream infection. And also, I want to point out at this stage, you need to look at the flip side of the coin. So why are we doing all of this? We're doing all of this to try and halt or at least hinder the surge of carbapenem resistance. So you need to look at whether resistance is developing. And I'm involved in a lot of microbiome studies and of patients with bloodstream infection on different antibiotics, and our group's also looking within these trials at what the effect of the gut microbiome and colonization resistance and sort of burden of antimicrobial resistance genes, what that is with carbapenems and beta-lactamase inhibitors and all these other antibiotics that we use, because it's one thing to prove non-inferiority, because meropenem is a fantastic drug for these infections, but you need to prove that there is a beneficial effect. And I think that certainly clinicians are reticent on taking on all of these novel, often expensive agents because of the uncertainty in a lot of these surrounding a lot of these drugs. But I think if we can sort of investigate these appropriately and potentially prove a benefit, it might solve some of the economic problems with newer agents as well.
Adam, that was awesome. I'm so glad you're looking at the resistance piece of it too, because I feel that gets neglected, where people just assume that piece is good. And I just got to show this other piece. So the fact that you're trying to systematically do that makes me very happy.
It does complicate things a bit, because nothing's ever simple, but it's a start.
I'm really looking forward to Merino 3 and learning all about this new information that's going to come out. And for those listeners out there that are inspired after listening to Jason Adam talk to do your own trial, but you feel like you need some brushing up, check out sidp.org for the research mini series so you too can be statistical experts like them. I just want to say thank you both for joining me today and sharing your important work with me and all of our Breakpoints listeners. I think this has been a really, really excellent explanation of these two major studies. And I think both of you maybe avoided some nasty emails, as Jason put it. For our listeners, thank you for listening to Breakpoints, the SIDB podcast. I've been your host, Rachel Britt, and our featured speakers have been Drs. Jason Pogue and Adam Stewart. This episode was produced by Zara K. Escopar and myself, and it was edited by Kelly Hannon, Joanne Huang, and Corey Medler. Our production team includes Kelly Cole and Anna Zhao. The executive producers of Breakpoints are Julian Justo and Aaron McCreary. Our theme song was recorded by SIDP member Steve Smoke. You can subscribe to Breakpoints on Apple Podcasts, Stitcher, or wherever you get your podcasts. Thanks for listening and helping SIDP achieve our vision of safe and effective antimicrobials for now and the future.